Hello guys and welcome to this 10 minutes review of nephrotic and nephritic syndromes. At the end of this video, I hope you can stick in some high yield and important information that will help you on your USMLE Step 1 test day. So let's get started. The first thing you need to do when dealing with such kind of questions, you need to look for red blood cells in the urine. Any evidence maybe of red blood cell casts, hematuria, colored urine, etc. So if there is hematuria, then you're most likely dealing with a syndrome in the nephritic range, okay? Again, if there is hematuria, you're most likely dealing with a syndrome in the nephritic range. Otherwise, if it is just a proteinuria, then you're most likely dealing with a syndrome in the nephrotic range. With that being said, you can cancel out maybe 2 to 3 choices. And your next step will be to determine exactly which syndrome you're dealing with. So let's start discussing first the nephritic syndromes. Our first nephritic syndrome will be IgA nephropathy or Buerger's disease. So I want you to remember, this presentation of a child with the simple upper respiratory tract infection. And then a few days later, this child develops abdominal pain, arthralgias, palpable purpura, especially on the buttocks. It's IgA vasculitis, Heinrich-Schönlein purpura. If this child develops hematuria, then it is IgA nephropathy, Buerger's disease. Just putting IgA things together, okay? You need to remember as well that IgA nephropathy is episodic. If there is any mention in the question stem of a past episode, maybe 6 months ago or a year ago, of hematuria in this person, then you need to keep IgA nephropathy in your mind, because this disease tends to reoccur with recurrent URIs. Okay, so IgA nephropathy is episodic. Finally, you need to remember the IgA depositions in the mesangium. Okay, IgA nephropathy, IgA depositions in the mesangium. Let's move on to the PSGN, post-streptococcal glomerulonephritis. So, if the question stem mentions any evidence of a streptococcal infection, maybe impetigo, maybe pharyngitis, whatever, and then 2 weeks later, hematuria, you're dealing with PSGN. Done, okay? Streptococcal infection, 2 weeks later, hematuria, then it is PSGN. But sometimes the question is ambiguous somehow. You can't really tell whether it is a pharyngitis or a simple URI. And you need to differentiate between the PSGN and IgA nephropathy. So, we first mentioned that IgA nephropathy, Buerger's disease, tends to be episodic. Okay? PSGN is associated with hypocomplementemia. So, PSGN, hypocomplementemia, IgA nephropathy, episodic, okay? There is the starry sky, lumpy bumpy appearance on the immunofluorescence. It's just a fancy way of describing the granular appearance for this disease, and the subepithelial humps. Okay, so PSGN, subepithelial humps. Now let's move on to the Alport syndrome, which is a defect in the collagen, okay? So, there is this famous presentation of a person who can't pee, can't see, can't hear a bee, okay? And on the electron microscopy, there is that thickening and splitting, okay? And some describe as well the basket weave on electron microscopy. So, recap. Alport syndrome, can't pee, can't see, can't hear a bee. A problem in the collagen, and thickening and splitting, as well as the basket weave appearance on electron microscopy. Let's move on to the rapidly progressive glomerulonephritis. So, if you're faced with a nephritic syndrome, and this syndrome is rapidly progressive, okay, and there is a description of crescents in the glomeruli that are composed of fibrin and macrophages, you're dealing with RPGN. And you want to identify the cause of RPGN, then you do immunofluorescence, okay? So if the immunofluorescence is linear, then there are antibodies against the basement membrane, which is Goodpasture syndrome. So linear immunofluorescence, Goodpasture syndromes, antibodies against the basement membrane, hemoptyses plus hematuria. Okay, hemoptyses plus hematuria, linear immunofluorescence, antibodies against the basement membrane, Goodpasture syndrome. If the immunofluorescence is negative, okay, then you need to think about the ANCA vasculitis. It may be P-ANCA or C-ANCA vasculitis. And finally, if it is granular, then you need to look for another evidence to identify the cause of RPGN, okay? Because most of these syndromes have granular appearance on the immunofluorescence. So mainly we will focus on the linear, Goodpasture, negative, Part C immune, either P-ANCA or C-ANCA vasculitis. We will discuss these vasculitis on a later video. So now if it is just a nephrotic syndrome, just protein, no hematuria, no red blood cells, then let's find out these syndromes. So first of all, the minimal change disease. So when discussing the minimal change disease, you need to remember that no changes on the immunofluorescence, no changes on the light microscopy, just two things. So that is the normal thing on the electron microscopy. Here you can find the podocytes, the basement membrane here, and the endothelial cells. Okay, these are the endothelial cells, and this is a red blood cell. So here you can find the fused podocytes or effaced podocytes, okay? And as well the loss of the negative charge in the basement membrane. So effaced podocytes, loss of negative charge in the basement membrane, which actually facilitates the loss of albumin in the urine in the minimal change disease, and every other thing, immunofluorescence, light microscopy, is normal. Done. Let's move on to the focal segmental glomerulonephritis. So on the light microscopy, that is the normal glomerulus, and here you can find focal hyalinosis and sclerosis, focal hyalinosis and sclerosis, okay? And this hyalinosis and sclerosis tends to occur in segments of the kidney, okay? So it is focal in the glomerulus, segmental in the kidney, focal segmental glomerulosclerosis, hyalinosis and sclerosis, okay? On the electron microscopy, the same fused podocytes, and that's it for FSGS. Let's move on to the membranous nephropathy. So first thing you need to remember that the immune complex here is composed of antibodies against the phospholipase A2 receptors, okay? You need to remember as well that membranous nephropathy is the most common cause of a nephrotic syndrome in lupus patients. Again, membranous nephropathy is the most common cause of a nephrotic syndrome in lupus patients, okay? On the electron microscopy, you can find that dome, spike, okay? Spike and dome appearance on the electron microscopy, and the subepithelial depositions. So membranous nephropathy, spike and dome, subepithelial depositions. Let's move on to the amyloid and diabetes. So for the diabetes, you need to remember the Klimestyles-Wilson nodules, okay? And for the amyloid, it's just detecting the amyloid in other tissues in the body, the Congo red stain, the birefringence, polarized light microscopy, etc., etc. Okay, just remember that the amyloid causes a nephrotic syndrome. Here is a Congo red stain of a glomerulus. Okay, so if it is proteinuria plus hematuria, then it is a nephrotic syndrome. So we have two syndromes here. First one is diffuse proliferative glomerulonephritis. You need to remember that it is the most common cause of a nephritic syndrome in lupus patients. So, the most common cause of a nephrotic syndrome in lupus patients is membranous nephropathy. The most common cause of a nephritic syndrome in lupus patients is diffuse proliferative glomerulonephritis, DPGN. Okay? So, DPGN, lupus nephritic syndrome. Nephritic syndrome. So, you can find here as well the wire looping here and here as well. Some here, okay? Wire looping of the capillaries on the light microscopy. Finally, let's move on to the MPGN, membranoproliferative glomerulonephritis. So this syndrome has two types, type 1 and type 2. And here you can find the tram track appearance on the light microscopy. It is most likely associated with type 1, but let's consider it for now that is, for type 1 and type 2, most likely associated with type 1. Okay. So tram track appearance, MPGN, type 1 and 2, most likely type 1. Discussing the two types of MPGN, let's talk about type 1 first. It is associated with the hepatitis, okay? Hepatitis infections, HBV and HCV. There are, other associations, and there is an association of hepatitis with the membranous nephropathy, and other associations with the FSGS and etc. You can read them on your own, but I think that the most high yield one is the HBV and HCV association with type 1 MPGN. So type 1 MPGN, HBV and HCV. Okay. As well as subendothelial depositions. Okay. And finally, we will discuss type 2 MPGN. You need to remember that C3 nephritic factor, so it's an antibody against the C3 convertase that stabilizes actually the C3 convertase, so it can, continue activating the C3, okay? And finally, intramembranous deposition, it's dense deposit disease. So type 1, you remember, HBV and HCV, as well as subendothelial depositions. Type 2, C3 nephritic factor, the antibody that stabilizes the C3 convertase, plus intramembranous depositions. So, finally, let's discuss the depositions. So, they are all subepithelial or subendothelial or intramembranous. Discussing the subendothelial, anything that has PGN, okay, proliferative glomerulonephritis, then it is subendothelial. So MPGN type 1, DPGN are subendothelial. MPGN type 2 is the only one with intramembranous depositions, okay? And finally, the PSGN and membranous nephropathy are subepithelial. Okay, so again, PGN, MPGN, DPGN are subendothelial. MPGN type 2, basement membrane, PSGN and membranous nephropathy, subepithelial. And we're done. So I hope you guys have enjoyed this video. Leave your opinions in the comment and best of luck with your test.